So now we have to figure out, we have a patient who comes in, we want to know if we have the accurate diagnosis, is it Crohn's or is it ulcerative colitis? But sometimes we're put in a position where it's not so easy to figure out if they do have one or the other, if those should be the two types of diseases we want to think about. And that phenotyping actually may be quite helpful in trying to understand which of the patients may actually be at most risk, because when you first diagnose somebody with inflammatory bowel disease and you're trying to have the conversation with either the patient or the family or both, their questions start really about which medicine should I take, what are the risks for it, and really which one should you recommend to them, because you really want to give the most effective treatment early on, and that may be that you need some evidence to support your recommendation to the family. So we'll go on from there. Okay, so as we said before, inflammatory bowel disease has really been looked at as being one umbrella of either Crohn's or ulcerative colitis. But I would tell you that it really is a spectrum, and when you think about it, Crohn's or ulcerative colitis really are more of a continuum than they are two separate diagnoses. And I think if we begin to understand, both for ourselves and for the families whom we counsel, that you really should not get stuck on one title versus the next, I think it will allow them to understand that there can be a shift in sometimes the diagnosis, but as importantly, that some of the medications that we use are actually effective for both. So the important thing, again, is to really look at the patient and really try to the best of your ability at the time of the initial diagnosis to get the accurate diagnosis as much as one can be. So clearly it's taking a clinical history. You want to know when the symptoms began. You might want to understand, had there been any long history of abdominal pain, growth failure, possibly something back in the history that originally was not thought of. Family history, as we know, is incredibly important, so certainly asking if there had been anyone else in the family with any type of symptoms, or certainly those who had been diagnosed with inflammatory bowel disease, but you may want to go one step further and ask if there are other autoimmune diseases that are in the family, such as arthritis, such as thyroid disease, etc. So it's really going back and taking a look at the history. Meticulous physical exam, and I say this so much as an absolute, because there are so many patients who come into our office, and if they've come from the pediatrician, sometimes they have not had that full exam, which does include a rectal exam, and there have been plenty of patients who've come in who've been anemic, and no one's actually looked at their bottom to see that this was a patient who had severe rectal disease and had never mentioned it, especially if they're more shy about that. So it's really doing that physical exam, including looking at their rectum. Blood work, routine, you always want to send off a CRP and an ESR. There are plenty of patients with inflammatory bowel disease that may have a normal ESR, but their CRP might be elevated. And in general, because we have to make some general comments, that those with Crohn's disease tend to raise their CRP more than they necessarily raise their ESR. So it's always good to send off both. Now, stool studies are important even if the patient's not complaining of diarrhea, because you really want to understand, is the calprotectin elevated? And this may be something you may begin to judge your effectiveness of treatment. So sending that off may be important. And certainly in those who already have inflammatory bowel disease, you want to make sure, should there be a flare, that C. diff is not part of the picture. Again, upper and lower endoscopy, and these days, especially in pediatrics, I think that being as comprehensive in understanding the GI tract from mouth to anus is essential in being able to advise families and to choose what type of treatment would be effective. So, and making sure that when you do document what their diagnosis is, exactly where the disease is, because that too may impact the type of treatment that you would recommend. Imaging is important because, as you know, with endoscopy, you can only go so far by doing an upper, and certainly so far by doing your colonoscopy, and that we have many inches of small intestine that have to be characterized to see if it's indeed normal or perhaps if there's some disease going on. And there are some specialized testing, which we'll talk about, that may include genetics and some IBD serologies. So why do we want to be as accurate as possible? Because we all understand that there's heterogeneity in the disease presentation and course, and that individuals' response to therapies may be different. So this is a graph that you've probably seen over and over again, but I think it continues to have the impact because we have many patients, especially in pediatrics, where we have not had months or years of disease before they present. And by looking at looking at the very beginning of disease presentation, that more often than not, it seems to be more of an inflammatory component. And as time goes on where there's either no treatment or ineffective treatment, that inflammatory state ultimately winds up going to a stricturing type of presentation. And again, remember that the best meds that we've ever had either yesterday, today, or even in the future will never be as effective in a strictured down, scarred intestine as it will with a freshly inflamed. So again, just saying that early understanding and getting that effective treatment in early on will have the best outcomes for our patients. We also understand, for those of us who take care of IBD, that it's not just, you diagnose them, you put them on good treatment, and that, they seem to coast along. Even with those where you've had a good response, we know that IBD seems to have a waxing and waning type of activity. And I say to my fellows, there's basically 4 times a year that we will get most of our phone calls of those patients who are otherwise well or otherwise well controlled. Tends to be around August, September, December, May, June, and the anniversary month of when they first got sick. So there's something that happens in our environment along with lifestyle that may ultimately cause these undulating type of disease presentations. But again, uncontrolled disease ultimately will go over to a stricture type of presentation. We also know that the natural history, especially with UC, that 20% will go on to colectomy for those who are medically refractory, and that in in Crohn's disease, 50% of patients within 10 years will go on to some type of surgery. So this is information that we know, looking in the future, this is what we have at this moment to deal with. So here we have our crystal ball, and if we had the ability to have a crystal ball in our offices and be able to figure out which patient would go on to more complicated disease versus those that might go on to a mild form of disease, then our treatment strategies would be adjusted as such. So what causes the disabling disease? What clues exist out there? Well, we could say for Crohn's disease, there are some things that at presentation that should give us a clue that this is a patient that is probably going to have a more difficult course, who may need to have more intense therapy offered to them. Certainly those who have perianal disease, who have deep ulcers during the endoscopy, whether it's your upper or lower, but for sure definitely in the lower endoscopy. If they have extensive small bowel disease, again, the importance of examining that small bowel, if not by typical imaging through something like a CT or an MRI, but even thinking about capsule endoscopy if need be. If they're ASCA positive, that is a patient who will more likely go on to an aggressive form. Anybody who presents with any type of stricturing or penetrating disease tells you that's the patient who may go on for sure to get some type of complication from their disease. And especially in children, we think about growth failure, but I would even tell you weight loss would be a clue. Younger age, and then if they actually need steroids at the time of their diagnosis. So if you think about nowadays, we're much more skittish about starting steroids, but if it gets to the point where you've evaluated this patient and they're not doing well and steroids seems to be the thing that you need to give them early on, that's another clue. Certainly for ulcerative colitis, if they have extensive disease, this is not just the patient with proctitis, but those, especially in pediatrics where a majority of our UC is pancolitis, that is a patient who may go on to a more complicated course. Those who are diagnosed with primary sclerosing cholangitis, that although their colitic symptoms may not be as severe, those are the patients who could go on for complications of certainly cancer and maybe even those who need to go on to liver transplant. And again, younger age and early use of steroids. So phenotyping is the next information that we'll go over, but that actually may give us, again, some important clues to the patient that may go on to a more complicated course. And so this is not sending off extra blood tests that may be expensive. It's not necessarily sending off the genetics. It's doing our routine day, but making sure that we actually phenotype. So there are three major ones that we look at for both Crohn's disease and ulcerative colitis. The Vienna classification was put together in 1998, and that was specific for Crohn's disease. It looked at age of diagnosis, the disease behavior, and location of the disease. The Montreal, which was published in 2005, now took into account not only just Crohn's, but ulcerative colitis, again looking at age, disease behavior, and location. And in 2011, the Paris classification, which is specific for pediatric use and Crohn's disease, not only looked at age, disease behavior, location, but as you all know, for pediatrics, growth being an essential part of what we look at. So not to get too complicated on this slide, but just looking again at the Vienna classification for Crohn's, looking at the age of diagnosis, which really broke it up into two major categories of less than 40 or greater than 40, looking at location, terminal ileum for L1, colon, ileocolon, and then the upper GI tract, and then the behavior. Was this non-stricturing, non-penetrating? Was this stricturing, or was this penetrating? But there were problems with the Vienna classification in that it seemed to be too much of a broad category for age. It seemed also that there were some patients who had both stricturing and non-stricturing, and again, at the time of diagnosis, it wasn't as exact. The Montreal classification came out for Crohn's disease, and how this was different is it did break it up now a little bit more pediatric friendly in the sense that A1 was less than 16, A2 was your younger group of patients, and A3 for the older. Although I say less than 40 is still not older. Location, again, being as important, is it ileal? So the ileal could mean ileocecal, by the way, but was L2 different from L1, where it was only in the colon? Again, colon being the one area where we can sometimes have difficulty in classifying the patients, or was it just to the upper GI tract? And again, looking at the behavior, non-stricturing, stricturing, penetrating, but this too now had a new category of perianal disease, which, as we saw from a previous slide, could indicate more aggressive disease. So this is a nice picture that you certainly may want to look at, but again, just looking at where the different anatomical distribution of disease was, L1 versus L4, and again, looking at disease behavior, how it might turn out to be. On this part of the slide, it also indicates that there are some other autoimmune, quote, quote, or immune-regulated diseases that you might want to think about that could possibly be within the family history, such as MS, such as autoimmune thyroiditis, etc. So Montreal classification, as we said before, also includes ulcerative colitis, and how this was helpful is it actually broke the phenotype into severity along with extent. So as you can see, looking at the different parameters here of what a patient may present in the office, you might characterize them as S0 or S1. Again, nothing that costs money to the patient, but actually helps phenotype for you and be able to characterize these patients as either being a mild form or possibly a more aggressive form. But when you look at the Vienna versus the Montreal for Crohn's, again, you could see how these two compared. So again, telling you that the Montreal was a little bit more specific. And I would tell you for the adult population, seems to be a very nice phenotyping system. But when we look at pediatrics, again, we're now seeing, as we understood for Dr. Benchmal, that we're now beginning to see IBD not just for patients who are less than 16, but now for patients who are much younger than that. And for those of you who are pediatric gastroenterologists or other healthcare providers, we know that for the younger population, meaning those children less than 10 years, and I would say less than 8 years, that they present very differently than what we see in either our post-pubertal patient or our young adult. We don't seem to get ileocecal disease in the 5-year-olds. It tends to be colonic. So this was an important advancement for pediatrics, looking at the different subtleties. So looking again to see breaking up the age presentation now differently. but also understanding that in many of our patients, it could also mean small bowel disease and extensive small bowel disease, and how the Paris classification was able to further give us some characterization of these patients was to look at breaking up the L4 into disease that was proximal to the ligament of Treitz, or L4B, meaning that might be distal or proximal. And again, looking at disease behavior, that we know that there are plenty of patients who are not just stricturing or penetrating, but that they have both, and so allowing these both to be characterized by themselves. Perianal disease, just like what the Montreal had, but now for children we had growth. So was there evidence of growth delay? Was there not evidence of growth delay? Again, giving us more characterization. And as you can see here, this gives you some understanding of how you characterize what is growth delay, and looking again at linear growth as being an incredibly important parameter for pediatrics. Additionally, there is a Paris classification for pediatric ulcerative colitis, not incredibly different than what the adults have, but as we know, for children less than 10 years, and again, for sure less than 8 years of age, the colitic IBD tends to not just be segmental, it's pan-colitis. So this added another dimension to phenotyping. And then also, clinical remission, mild UC, for children, we tend to either see severe or not severe. And at least in my practice, I will tell you that within the first 3 months of presentation, I can almost predict which patient will have their colon after 12 months and those who will not. And unfortunately, this does give us a big understanding of where we need to be aggressive early on in their diagnosis. So there are serologies and genetics, so they do cost money, saying that phenotyping doesn't cost anything. But again, this still may be important information that, so many families, understandably so, are very concerned about putting their child on a medication that has lymphoma. And almost every single young parent who comes to our offices nowadays are very internet savvy. They read a lot of things, not only about the condition that their child has, but treatment options. And understandably so, they're very concerned about the risks of the drug, including lymphoma. And the one thing that I always say, that I am not afraid of the medications, I'm more afraid of undertreated disease. And so sometimes you need to have more information for them to feel as comfortable as one can be with starting effective medication, and sometimes we need to have more evidence. So that might be serologic markers. So we know that there is a dysfunction between the microbiome environment and that person's immunologic response to it. And so these are some serologic markers that one could send off. And Dr. Dubinsky, who you'll hear from a little bit later on this afternoon, has shown in studies that show that the more markers you're positive for and the higher the titers, the more likely that you will have complicated disease. And Jim Markowitz also presented that, and I have a slide for you that will talk about it. But again, looking at the calprotectin to see if that might help, again, information. So again, this is another slide just looking at serologic markers. And as you could see, as in before, that there is a discrepancy for those children who are less than 8 years of age versus those who are now young teenagers, and that there is a difference when looking at the different markers about who may, at presentation, have positive markers. So again, when you're setting off those markers in the little ones, it may not particularly be as effective as sending them a little bit later on to predict who they might be. And looking again about the stabilization of these markers, if you look at the presentation, the younger patients tend to have more of a CBER1 antibody positive marker versus those after the age of about 9 or so that may have some stabilization, showing that ASCA tends to characterize their disease. The genetics, as we've heard before, over 160 markers out there, that although we have some that are more specific for Crohn's and more specific for ulcerative colitis, there are many that overlap, but it just tells you about how many different markers are out there that characterize our patients, which tells us that genetics alone cannot account for what we're seeing, and that there's many different pieces of the puzzle that put patients together for their, not only their presentation, but perhaps their future. We know that there are many different genetic mutations that may affect not only epithelial barrier, restitution, apoptosis, their innate or their adaptive immune system. So looking at genetics may be helpful, but it doesn't give us answers to everything. So now we have the ability to phenotype, we have the ability to perhaps understand who they are as far as their serologies. You may have some information about their genetics, so you go back to the discussion to the families about what exactly one should do. So we call this risk stratification. Families want to know, if I'm going to put my child on a medicine, does their presentation really warrant them going on this? And so this is part of our medical decision making. It's a constellation of activities where we take labs, we take some clinical testing, and we want to determine what is that patient's risk for developing that particular condition and its progression or lack thereof. And so then that may help us in understanding which patient we would recommend for biologics versus maybe immunomodulators. So again, just taking a look at serologies and genetics, what you can see from these two graphs, just looking at antibody levels, that if for this Kaplan-Meier curve, time to surgery, if you had no positive antibodies, the likelihood of you going on to surgery was much lower than if you had multiple numbers, meaning 3 or 4. And looking at your NOD2 positive or negative status, that if you were NOD2 positive, you were more likely to go on to some type of surgery than those who are NOD negative. So again, maybe information for those patients that you need to have that conversation with. There are different types of laboratories that will give us further understanding. So here from Prometheus, you can see they have the serologies with all the different microbial antibodies. You have some genetics that look at apoptosis, the extracellular matrix, and some STAT genes, as well as your markers. And based on this, through an algorithm, they could say whether you have Crohn's or whether you have ulcerative colitis, or it's inconclusive. But I would tell you that I spend more of my time looking at the individual results than I do necessarily what the algorithm tells me. Because if there are patients that are double ASCA positive, which probably wouldn't give us a negative IBD, or if it was slightly, you need to look at it, you need to look at the genetics. So it's really understanding this well. So there was a study that was just recently published in The Lancet in 2016. It was an adult study that looked at the association between phenotype and genetics. They had a very large population of about 30,000 patients, a little bit more Crohn's than ulcerative colitis. They looked at 3 major loci, the NOD2, the MHC, and the MS1, and they tried to see what were those 3 major loci and what were the phenotypes that they may look at. So what they thought about is that instead of characterizing somebody with either Crohn's or ulcerative colitis, they felt that looking at, again, disease distribution using the Montreal classification, that maybe we should be looking at ileal Crohn's separately from colonic Crohn's versus ulcerative colitis. They did note that in Crohn's disease, patients tended to be younger, they were smokers, and they had family members than those with ulcerative colitis, and I think we still see that where we are. And that extensive disease was more characterized in the younger patient for either ulcerative colitis or Crohn's, and that although genetics helped understand where the disease location might be, it didn't necessarily tell you about disease behavior. So taking a look at these 4 graphs, what you could see here is that inflammation tended to be the major characteristic early on in your disease, but that ultimately, if there wasn't effective therapy, you went on to stricturing or penetrating. Looking at the 3 categories, as we talked about before, either ileocolonic, and this is not ileocecal, this is really in the colon, versus ileal versus colonic, that your disease distribution really didn't change over time. Again, this is not pediatrics, this is adult. But again, now looking at those patients who went on to any type of surgery, you could see that the ileal disease tended to be the worst prognosis, and that if you had extensive disease for ulcerative colitis, again, you went on to the worst prognosis. So again, phenotyping really being quite helpful and not necessarily the genetics. So the conclusion from their study was that phenotype and location remains fixed over time, again for adults. Genetics may help determine which type of phenotype you are, but that the genetic association really didn't have that much to do with disease behavior. However, Although genetics did help determine what type of phenotype you are, location was the major driver of disease over time. So those patients who have ileal disease tended to have the worst prognosis. And certainly if you had pancolitis or extensive colitis, you were at higher risk for colectomy. So Crohn's Prognostic is another test that's available, and again, looking at your IBD markers, but now with the nod to SNPs. And again, this may be important information to show your patients that over time, you may get into complications with your Crohn's disease. So this is I borrowed this slide from Marla. It was Corey Siegel's study, but if you take a look at a 16-year-old girl with small bowel disease, which we discussed might be a clue to us of having more aggressive behavior, and perianal disease, and you were to look at that, if this patient had not received any treatment, or we'll say ineffective treatment, then the risk of this patient having complications, you can see, happened within the first 2 years. If there was early treatment with an immunomodulator, you might modify the natural history of the disease, and if there was effective therapy, hopefully with an anti-TNF, you may actually decrease your overall complication. And again, it looked at some of the personal characteristics, the disease location, some serologic inputs, along with some genetics. So in conclusion, meticulous evaluation at the time of diagnosis is essential to the best predict which patients may be at higher risk and who may have complications over time. Location, disease behavior, serology, and genetics may help with the patient to predict if they will have aggressive disease. There are predictive models that are out there that may help you as the clinicians to help guide families and patients to what might be the most effective therapy. And I would tell you again that the most effective therapy needs to be chosen at the early onset where you have inflammatory disease and not necessarily scarring. So our ultimate goal is to have, for these patients, a molecular profile for each patient at the time of their diagnosis, which may include serum, their DNA, tissue, their intestinal microbiome, which may help choose the most effective management to treat their disease. Thank you.